We saw the works of some of my students. That's good, right? You can hear me at the back. Starting from Fabio Iris and then Shobmishta Pragna and then Shantanu Bonik. They did their projects. And then this work was done by Jayashree Chakrabarti, who came from IIT Kharagpur to do part of her PhD work with me. We discussed again with Dr. Desatel, and the question was, we were taking all these regions of interest at various positions within the mammogram, detected using node analysis, and then we were treating them all equally in terms of potential regions of architectural distortion. And we were computing spreads of angular distribution. And then we asked the radiologist, are all these equally likely? Are there any properties that are different depending on the position? And he said, yes, of course. Depending on the position of where you are in the breast, the oriented pattern will have a different orientation, normally. So in the normal breast, tissues converge towards the nipple, as I mentioned a few times. And that's because the milk ducts take milk that way towards the nipple, and all the supporting structures are around these structures to support them and hold them together. So the overall texture of a mammogram is expected to have oriented texture this way. So Jayashree drew this diagram based on other pictures we had seen in the literature. And then obviously if you have a region of interest here, it should be having texture oriented that way. If it is here, it should be oriented that way. So we said, okay, let's take that into account in the analysis of regions of interest and detection of architectural distortion. So the main idea is, these are what we call the loci of breast tissue, expected. So to draw these lines, we need some reference points, landmarking. I talked about landmarking of CT images, where we encountered ribs, spinal canal, hips, and so on, hip bones or the pelvic bone. In a mammogram, if it is an MLO, medial lateral oblique view, there will be the pectoral muscle. Mostly straight line. If you can fit an approximate straight line, that forms a reference to the chest wall. And the skin air boundary or the breast boundary needs to be detected. These are important references for these loci or loci, as you want to call it, plural of locus. And you need the nipple also to be detected. And there are many algorithms or procedures in the literature. I have not talked about detection of the nipple. We have some methods based on the Huff and Radon transform to find the point of convergence and a point on the skin boundary or near the skin boundary. That's in the new edition of the book, but I don't have a presentation on that material. But let's say you have a procedure to detect the edge of the pectoral muscle and the breast boundary and the nipple. And with that, we can form the expected loci. So these are the breast boundary approximated by fifth order and second order polynomials. The nipple is also detected marked. A straight line approximation to the pectoral muscle is marked. Now the pectoral muscle is going like that, so it's not a very good approximation. But all we want is this line as a reference to the chest wall, from the chest wall to the nipple. So the breast boundary is broken into two parts, possibly three parts if there is a little part here. But we fit these contours to just get an approximate or smooth representation. And then we draw a similar contour by interpolation from the top edge, which is in the pectoral muscle, to the nipple, and this is derived from that contour. In the case of MLO, the chest wall is assumed to be this edge of the image. The upper and lower parts of the breast boundary are approximated by second order polynomials. This is fifth order, the others are second order polynomials. The nipple is there, and perpendicular to the chest wall, assumed to be here, is drawn, and that's another reference line. Based on these, the images are broken into regions marked as R1 to R7. In some images, you may not have R4 and R7. So what are these expected loci of breast tissue? And here again, Dr. Desertel told us the breast boundary is related to this, these contours. So knowing the breast boundary, you should be able to extrapolate or interpolate, as you wish to call it, and get the other contours for every pixel within the mammogram in these regions. For that, the images were broken into these regions marked as R1 to R7. And there are some different procedures for these as to how to interpolate, but they're all interpolations, so I won't go into the details. If you go to Jayashree's papers with me, you will find the exact procedure. So essentially, here, using this upper part of the breast boundary and the lower part, and drawing some limits, there is a limit here from the top left corner to the nipple, which is derived using the outer breast boundary, and in between these are all interpolated versions of those contours. Similarly here, these are interpolated versions, and you get these contours for all pixels in the mammogram. I'm showing only a few of these contours. Similarly for the craniocaudal or CC view. So landmarking is required first, and the breast boundary itself approximated by simpler curves. Those curves are used to interpolate and get the other curves, which are taken to represent the expected orientation of breast tissue at every pixel in the mammogram. So here, breast tissue is expected to be oriented that way, and here this way, and there that way. We have seen such patterns. It doesn't happen always at every location. So this is a model. Now, if there is architectural distortion here, then there will be spicules going this way and that way, and which are every other way. But we expect the orientation to be like this. And if your window is only this much, all lines should be oriented like that. Or the orientation in between obtained by interpolation for every pixel. So then ask for the deviation. Using Gabor filters, we have computed for the image the orientation field at every pixel. This says, according to our model of the breast, the orientation should be like that in the window. What is the difference between the two? If there is disagreement or lack of coherence, then there is some suspicious structure. So mark all the suspicious areas like before using node map analysis, and then do pattern classification, train pattern classification. The rest of the story is the same. So we compute divergence. Mn is the Gabor magnitude response. Theta Mn is the Gabor angle at pixel Mn. Phi ij is the expected orientation of breast tissue at that location, and do that. If the computed angle agrees with the model, the value is close to 0, cos 0 is 1, magnitude is high, so it will be high, normalized with respect to the Gabor magnitude. And this is coherence, they are agreeing. Take 1 minus that for disagreement, lack of coherence. It worked somewhat similar to what we had for coherence. So here is the original image. That's the point of, that's the region marked by the radiologist as architectural distortion. You see some other angles. And Gabor magnitude, Gabor angle, and divergence map. And we see a large one, but there are so many other large values. That's okay. There are many places where the angles don't agree exactly. This is the thresholded map. We can remove some points. Still there is a large value. There is a large value there. So apply this and break the image into parts, and take all these windows up to 30, we have 30 in this case, and put them through. And here, what is that? I think number 5. Number 5 is in the window marked by the radiologist. Not number 1 in this case, number 1 is somewhere else. So number 5 is there, that's fine. So now put them all through pattern classification as before. If we just look at this, the area under the ROC curve is 0.6, which is not good. 0.5 is random. 0.6 is a little better than random. Many of the heraldic features, if you were to look at them individually, they give you no more than 0.6, 0.65 area under the ROC curve in many of our pattern classification experiments. So individually, one feature will not give you 0.8 or 0.9. Not even, if you get 0.7, you are lucky. That's a good feature. So you have to put many of them together. And as long as they are complementary, then when you put them together through feature selection, then your area under the ROC curve will go up to maybe 0.8, 0.9 if you have a good set of features. So this is one feature. FROC gave 80% at 9.5 false positives, like before, using just this. So which is not bad as a starting point. Then for each of those regions that have been cut, do further pattern analysis. We computed some more measures of specularity and angular dispersion caused by architectural distortion. One of them is called divergence of spicules. So if you take one of these regions marked, those square regions marked on the image as suspicious regions, if there are spicules, this is the center of the window. If there are spicules, they're expected to be like that. So you find the angle using polar coordinates, alpha 1 and so on. And this is for a pixel in this window at angle alpha 1, if there is a spicule, then if there is a large value of the magnitude, then if it agrees with the angle given by the model, then it is a spicule. So do that for all of these pixels. So what do we have? Mij, the Gabor magnitude or coherence value, times cos of theta ij minus alpha ij. Theta ij is the Gabor angle, alpha ij is the angle of a pixel in the range given by this illustration. So if the Gabor angle agrees with the angle according to this mapping, and if the magnitude, Gabor magnitude is high, this is based on Gabor magnitude, not the expected contours, over a window, then this is an index of divergence of spicules, we called it. So there are many spicules. And like that we defined radial and angle weighted differences. So we defined alpha 1 to alpha 4 to go 0 to 360, and R1, all these points are with distance R. Pixels with similar attributes at comparable radial distances or angles make small contributions to RWD or AWD. So these are measures of differences. If you have a spicule, they should be the same value or strong values along a given angle and a given radius, for various radius values for a given angle. There should be a spicule like that. Then for various values of R for a given angle, there should be high correlation. So like this, we defined a few more features. The basic idea is to characterize spicules in that window using magnitude and angle response detected by our methods. So we put all of these features. In the end, we got some 84 features, I think. Something will come up later. So the FROC curve, using only the peak values, I said 0.8 at 9 point something, 0.8 and close to 10 there. and you want to push this curve up here to this corner. And with selected features, all features gave the blue line, selected features gave a little better response. So feature selection is important. The difference is not much in this case, but it is important. So performance with 2 views per breast. Then we combined the information in 2 views, because 2 views are taken, mediolateral and craniocaudal. And these are the regions marked by the radiologists in red. These are the top 5 or 6? 5. Top 5 ranked regions obtained by this method. So number 1 is here. Number 2 is there. Number 1 here went somewhere else. So the others we don't care. After you rank order, then you still go through ROC analysis, FROC, and then say how many of these are number 1 and 2 and so on. You could do that, or give the sensitivity against false positive rate. So we got 86 features. Speculation features, we defined 12 of them. These are our measures. Hierarchics and loss texture features, fractal dimension 25. Angular spread and entropy, I described those. Our own design, 15 features. Now, Jayashree also did another project where we said there should be some agreement of angle also in a small window of analysis. So just like you do gray level co-occurrence matrix using Haralick's statistical measures, we said we will do angle co-occurrence. So we asked the question, if the angle at this point is this, what are the angles of the neighboring pixels using Gabor output? They should all be similar if there is coherent orientation. It's like coherence. If they are scattered, then the angle co-occurrence matrix will be scattered. If they're having similar orientation, we get large values along the diagonal, similar to grayscale. Gray level co-occurrence matrix, but angle co-occurrence. Angle data will be obtained for every pixel using Gabor filters. So we computed statistical measures of angular dispersion. Now we will view it as dispersion instead of just co-occurrence of similar values. And we used 6 of those and 28 measures of Haralick's measures with angle coherence matrices. We computed 2 of them, 14 times 2. So these Haralick's measures are using gray level values, gray level coherence. These use angle coherence. And then some more measures of angular dispersion and correlation using those Rose diagrams. And we put them all, 86 of them, through feature selection with stepwise logistic regression. And then different classifiers, and the Bayesian gave the best result with leave one patient out. All the mammograms of that person will be taken out during training and then tested on all those images of that subject or patient. So we got 80% at 3.7 false positives per image, which is better than what I had mentioned earlier. And again, comparable to the results reported in the literature at that time for detection of masses. So we have pushed the potential accuracy of detection of architectural distortion close to that of detection of masses when that was a major topic of research. So to conclude this work, Fabio did his PhD, Shantanu did his PhD, Sharmista did her master's, and Jayashree did a part of her PhD on this. So all of that for this project, we made this claim and said our methods could detect or detected with a certain database breast cancer 15 months ahead of the time of clinical diagnosis. That is, these are prior mammograms. On the average, the time difference between the prior mammogram and when cancer was detected was 15 months. And that's when cancer was detected by a radiologist. So if we had access to the prior mammograms at that time, 15 months before cancer was diagnosed for these subjects, we would have detected that with 80% sensitivity and fewer than 4 false positive per patient here, not per image. So 2 images per breast. So that was a substantial result, and Shantanu won an award for his paper in IEEE Transactions on Medical Imaging from the Canadian Cancer Society. So as I said earlier, when Hounsfield won, Hounsfield being an engineer and Cormack being a mathematician, they won the Nobel Prize for medicine. That was big. Oh, engineers are coming into medicine now. And we were happy that Shantanu was able to get this Best Paper Award from the Canadian Cancer Society as an engineer. So a number of grants we obtained. Shastri Indo-Canadian Institute, after our earlier Prime Minister Lal Bahadur Shastri, there is an Indo-Canadian institute that gave some grants for collaboration between IIT Kharagpur and my team in Calgary. 2 students from there came and worked with me. Ashish Dhara also came and did a part of his PhD project. It's not in this seminar. And a number of others gave some grants. Dr. Desato is my collaborator from the screening program. Dr. Mukhopadhyay from IIT Kharagpur, Naga Mudigonda, Hilary Alto, Fabio Aris, Shantanu Bane, Shomishta Pragna, husband, wife, and Jayashree Chakraborty from IIT Kharagpur worked on this project. So there's a lot of work, as you can see. Once it is done, it's obvious. So if you go back to the beginning of this work, we had no clue as to how to do this, and there was not much in the literature on this. So over about 10, 12 years, this work was done. All of this that you have seen so far on architectural distortion. Okay, that's the end of this seminar. We will have one more on fractals today, but before that, do you have any questions? Yeah.
Kind of word of appreciation here, because most of whatever we do for a CAD kind of a diagnosis, what happens is once the cancer is there, detection is very easy for even machine learning or deep learning kind of methods. But detecting the early signs is more important. That's what the research is like. So we have to pay attention there and while we as researchers here. So I think I'm astonished in like, okay, the computer can detect before the radiologist like.
No. Okay, we have to be careful there. We have to be careful there. A very famous computer scientist from Canada said, computers will replace radiologists, radiology is dead, and then many students did not go to radiology in Brazil. My collaborator, I mentioned Dr. Marcelo, he said students are not coming to radiology because this famous computer scientist said, oh, AI will take over. No, AI will not take over anything. Computers will not take over everything. They may take over. We should still do 2 times 3 is 6 or whatever multiplication at some checkouts in stores. Sometimes it so happens that if the power goes down or if the checkout is not working, then they have to shut down the whole store. Previously, when I was a kid, we would go shopping and the guy would say half kg of this, 10 grams of that, 50 grams of that, and he would just rattle off the numbers and he would say your bill is so many rupees, and he wouldn't even write, or he would just come up with the number. Sometimes he would scribble. He did all that mentally, and then, but nowadays it is difficult. About 2 months ago, the Calgary Public Library system, computer system was hacked, and they had to shut down. It's a digital library. So they said they shut down the whole library for a few days. There was a security concern, yes, but because of hacking of their computer system, they shut down the whole library. Libraries have nothing in them. Even at the university, the libraries are empty, hollow shells. They are ghostly or ghastly buildings. There are no books there. This library has books. What's the problem in telling you want this book? Take it or sit here and read it. They shut the whole library. And then after a few days, they opened, they said, no digital access, only paper books. At the University of Calgary, there is a huge library building, and I walked around, it's all empty. Students are sitting there, there's a coffee shop, drinking coffee and doing something on the computer. Okay, information can be accessed, but all the books have gone away into long-term storage somewhere outside the city. And in the library, there are a few books, but old books that are, in a way, it is efficient management. I should also agree that those that are not used are kept somewhere else. And when you ask for that, they will bring it back and give it to you. I can also get books from wherever in Canada, interlibrary loan. But libraries have changed quite a bit. But to depend completely on the computer system and say, I cannot give you a book because my computer is down, sounds a little strange. So complete dependence on computers is difficult, could cause problems. But coming back to your point, yes, we have shown that by appropriate design of computational procedures, it is possible to detect cancer before radiologists could detect them. But that doesn't mean my computer is better than the radiologist. In fact, all of this was developed in consultation with the radiologist, and the radiologist gave us these ideas by drawing pictures and explaining. But how to capture that into equations is what matters for us as computer scientists and engineers. Somebody else may interpret it in a different way and build other types of tools for the same purpose. Like for breast cancer screening, there were some news reports maybe 20 years ago that instead of taking mammograms, send a sample of your hair and they will do some tests and some biomarkers. And didn't go further. Breast cancer screening by mammography is still there. But it could be augmented with other tests. So instead of drawing blood, maybe a hair sample will do. But all of those need time to develop further. So my last seminar, I'm still preparing the notes for that. Like a PowerPoint I'm preparing for the last day. I'll talk about all of these as to where this is going, like what is radiomics and informatics, and I didn't have that. I looked at the title and said, oh, I should talk about those things. So I'm putting some of these notions together. I'll give you some thoughts about that later as to how these can be done, how these should be done, and where credit should be given. Any other questions or comments?
I have a question. When we cooperate with the radiologist, their way of approach for a modality is different. They use PACS and DICOM. And what we use is somewhat like AI. So how are we supposed to integrate both? Like you showed me an image on page number 17, slide number 17, where we saw the overlap. If the node which I have marked overlaps with the other radiologist, we say that it is fine. Otherwise, if it is not overlapping, it is not good. So how do you say that the radiologist will be correct, or the one we did not make the error is where?
There are a few different things you mentioned. PACS and DICOM have nothing to do with image analysis. PACS is picture archival and communication system to display images and transmit and store, and so that is different. DICOM is a standard that says what kind of header should be there, what kind of information should be in the header about the patient, the imaging modality parameters, and then how the image pixels or voxels should be stored. So they are just communication and archival system standards and systems. So from that system, you take your pictures out, the radiologist will view on a monitor, and we get the digitized images and we do the image processing. So that is one. AI has nothing to do with, I don't want to use AI. CAD has nothing to do with PACS and DICOM. They are just tools to facilitate the operation of the diagnostic enterprise, computer or radiologist. How do you say the radiologist marked it in the right place? That is trust and faith. The radiologist is the domain expert. And you and I can't question because we are not trained. We don't know that. So we take that, and the computer algorithms can detect most of them. Yes, we can see that. it is working, sometimes they fail. And we have asked Dr. Desertel, well, why is it failing here? This tumor doesn't have speculations. He has a nice sense of humor. He said that patient or this tumor did not read the textbooks. So they don't behave as textbook definitions. In biological systems, various other things happen in terms of variability being larger. But regardless, we have to take the domain experts' input or opinion as being valid. I cannot say, and I will not say, that my result is more accurate than that marked by the radiologist. There is no argument to support that. As I said, you can get it done by multiple radiologists, but instead of having multiple, it is better to have a consensus of the multiple inputs from multiple medical specialists. That has been done in some studies. So, did that answer your question? Okay. But I would not want to say these will replace the radiologists ever. That's not the idea here.
Anyway, there will be radiologists, they give input to this one and we build kind of a, what do you call, expert system or something like that. True. That gives some results. The common man is able to see the results of that. He has his own interpretation of that. Before we go into the doctor, we see the Google and what is this tablet, what is the side effects and all. This is the generation of that one. We go and recommend the doctors that you give me this.
Yeah, that's okay. I mean, you should also be informed. When we go to the doctor, we should be informed. You don't want the doctor to spend half an hour explaining to you what is this. And sometimes, in fact, my family physician, when I ask questions, he will go to Google or he will go to NIH or Mayo Clinic or Cleveland Clinic Foundation, all these things. And then he will print it out and give it to me. And sometimes he says, well, you go and Google yourself. He knows what I do. So for me, he will say, but for somebody else, he may not say that. He may actually sit and explain. But if you are prepared, then you should be able to ask questions and understand the response. So when you go to a medical expert, then it will be good to have some knowledge. And there will be cases where we know nothing. Something happens and I go and say, there is this and please help. And whatever my doctor gives, I take that. If I want to read more, yes, now we have Mayo Clinic, Cleveland Clinic Foundation and many others, NIH. We go and read. But I can't do self-medication. Here you can go to the drugstore and say, I want this. In Canada, you cannot. There are these Tylenol and other things over the counter. You can go and buy cough tablets and so on. But if you want a specific prescription drug, you must have a prescription. Here also it says by medical prescription only, but they just give. You go and ask, they give it. That should not be the case. So all the files up to now are available on is it a Google Drive or something? Where have you? Google Drive that Dr. Raghavendra has prepared for you. I'll be putting four more files there, PDF files. The last one is still, I'm working on that. When ready, I'll put them and please download those later on, including this one. This is not yet there. You will get all of these PDF files. We have used fractals in some of our research projects. I talked about fractal dimension computed from the frequency domain using the radial frequency past spectral density. We did some fractal analysis of knee joint vibration signals. Then I thought it would be nice to put a seminar together as a general information seminar on fractals. What are fractals? What do they look like in biomedical signals and images, and how can we quantify or characterize the fractal nature of signals and images. I mentioned this crest or logo of the university. It's It's not a logo, it's called a crest. This is the new version for digital scalability and all that. So note the standardization of color, and note also the color of the horn of this bull. I mentioned, note that the books are empty. That's the old one. So there was the books had some scribbles. There's no text. Why is that not moving?
This plus zoom is there.
I'm trying to, okay, come down. No, not that much there. Okay. So previously the book had something, this flower also had something. There was the motto of the university, I shall lift up my eyes. And it was translated to eyes high. And that's in Gaelic language from Scotland, I think. The name Calgary comes from Scotland. And the bull also has some hairstyle. But the bull had a red horn. So red it looked like as though it did something. They changed the color of that. So sensitivity of the public and designers has changed. I think I told you, or maybe we were talking, some 20 years ago we were told not to use red pens in marking exams. We were told it's offensive. So previously there was only blue and black, or blue-black, and then came green. My father used to use green always, and then came red. And now you have the whole spectrum, pink and purple and mauve and so nicer colors. But that changed. So what are fractals? I showed you this picture of a fern leaf. I plucked it from the garden. I don't think my wife was happy that I plucked such a big piece from her garden. It shows the fractal nature. One of the definitions is self-similarity at multiple scales. The same pattern occurs. Self-similar, like the same thing. So here we have a certain pattern of arrangement of leaves or subunits. Take each subunit, it looks like the same thing with the same type of arrangement of the subunit. But if I take this and zoom, you can see some structure, but they're not as separated. And if I take one of those little things, then it's lost. It's a physical thing. To make these patterns, you need the physical substance of that leaf. So there is a limit to that. As I mentioned earlier, if in computer-generated fractals, it keeps on flashing and zooming in and creating the same patterns, but that is not true in the sense it is simulated again and again and again. The same thing is projected to you, looks like it is coming from somewhere, but if you zoom in, the detail is lost after maybe 2-3 scales. What do we see in images? Macrolobulated versus microlobulated contours of tumors. That is self-similarity. Nested patterns are complexity of some kind. Smooth versus rough contours, convex versus spiculated contours, geometric versus space-filling curves. These are some kind of nested complexity. So these are two types or two views of fractals. Not always cauliflower, but cauliflower is a nice example. So I took a cauliflower from our kitchen, and if you take individual florets out, they look like the whole cauliflower if you zoom. So I took one of those, I don't know which one, and it is that. If I zoom this, it looked like the whole cauliflower. I took one of those and I zoomed that, sort of another cauliflower, but there is a limit. If I zoom this, it's just something. If I break it further, then I can't take any picture. You put it in a subji and eat it. So there is a limit to this in a physical image. A physical object rather. Now, given a fixed image of 1,000 by 1,000 pixels, let's say, You want to downsample it to see what happens at some other scale. If you zoom in, then cut it to 512 by 512 and so on. Go to smaller and smaller scale. But after maybe 100 by 100, anything smaller, there is not enough number of pixels there to form the pattern that you want to see. So there is a limit in a given discretized image or in a given physical object. There are limits to how many scales of this repetition of pattern can exist. So a few examples of fractals in the human body: the tree pattern of the bronchial tubes in the lungs, branching networks of blood vessels in the body, in particular kidneys, the His-Purkinje conducting system in the ventricles of the heart. You know that the heart has an electrical conduction system, like a wiring system of its own. So from the sinoatrial node, there is a bundle of conducting fibers going to the atrioventricular node. And from the atrioventricular node, there are two branches called the bundle branches. And then when they go to the bottom of the heart, they suddenly branch into numerous sub branches. And that is called the His-Purkinje conducting system. So that branching pattern for rapid stimulation of the ventricles from the bottom up, that is triggered by this network, which is similar to all these branching patterns. The convoluting pattern of the folds of the brain. Convolution here means convolved with itself, folded with itself. Convolution is, in English, it would be taken to mean folding. In mathematics, in image processing, it is the other operation, but there also you take it and sort of, it's not exactly folding, but it's called convolution there. Here it is interpreted as a folding pattern. So there are similar blobs like a cauliflower. Fractal dimension was defined by Benoit Mandelbrot in 1967, and he came up with this notion of self-similarity and fractal dimension. So one of his famous sayings, it's not here, he said, mountains are not triangles and clouds are not spheres. So they are more complex patterns. Overall, they're like that. But then you add details, you will see finer and finer details. You will get a PDF file of this later. So fractal dimension quantifies complexity as a ratio of the change in detail to change in scale of your measurement or viewing of the object or of the substance in the object or the pattern. For geometric shapes, fractal dimension is equal to Euclidean or topological dimension, 1 for 1D lines, 2 for 2D surfaces, 3 for 3D volumes. So this is for geometric patterns. Straight line is 1. But if you draw a curve, some wavy pattern, that's not a straight line. It is something between 1 and 2. 2 for a square. This is a flat rectangle. But then if it has some variations in gray level or some pattern, then it's more than 2. 3 for 3D volumes, but if that has some roughness like a cloud, it'll be more than 3, the fractal dimension. So for fractals, the theoretical fractal dimension is greater than its topological or Euclidean dimension. Some basic patterns that are well known in fractals: the Cantor bar, the first iteration, one line. Then you break it into 3 parts, equal 3 parts, and take one out and iterate. It's an iterative process. So take this, break into 3 parts, equal, take one part, the middle part out, and keep doing. So this is known as a Cantor bar. It's a fractal of some kind because of iterative patterns. Each one is a line, and there is a certain rule that the middle 1/3 is left blank. The middle 1/3 is left blank, and there is a blank portion here, and it goes on. The Koch curve is another, where you start with a straight line, break into parts, take the middle third and cut that in half and make a triangle there. And then take this, do the same thing. Cut in 3 parts, put a triangle in the middle, equilateral triangle. And for all of these. And keep repeating. So I try to make 2-dimensional patterns similar to that, but on a grid in a graphics tool. So some of these are not perfect because I can't make angles, lines at all angles. So angle placement I encountered some limitations in the very simple TGIF graphics tool that I used. You may have better tools and you may get a better result here. So there is this Koch snowflake where you do the same thing, start with a triangle and break this and make another triangle and break this and put another triangle and keep doing that. So there is self-similarity at multiple scales. Triangles, 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 big, medium, small, 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 and so on. But there is a rule as to how they are placed. There is some inaccuracy there because of the graphics package on a discrete grid. But that shows what the snowflake is. So I said, well, let me do that with circles. That's done with triangles. So what about macrolobulated versus microlobulated masses? So start with a circle and break that into thirds and draw circles. These are all circles, but the inside is blocked out. They're all black circles. So they overlap here. So I'm interested only in the contour. So no lobules. Now there are 6 lobules. I wanted to do 3, but I don't know why I didn't put it. The first stage is 3, then 6. And take each of these and make smaller circles and stick on there. The placement rule is the same as to how these are placed. So on these, now I put 3 more circles and so on. So again, there are some inaccuracies due to the discrete grid. So we could call this as a benign mass. This is a macrolobulated, perhaps this will be smoothed out. In reality, it won't be so sharp. It will be perhaps something like that here. And then microlobulated. If you do again and again, the lobules become smaller and smaller. So benign to malignant transition. And that is shape complexity of some kind, as we have seen in real mammographic mass contours I showed earlier in chapter 7. There is another pattern called the Sierpinski triangle. There is some placement rule again. You keep breaking and you get more complex pattern. There is another measure of complexity called lacunarity. That becomes evident here. Fractal dimension is based on what is present. Pixels that are having a value, 1 or whatever. Lacunarity is based on holes, what is not there. So you quantify the holes or absence of material. In a ligament, if there are tissue, collagen fiber tissues, that is fractal dimension. If you analyze the gaps between them, that is called lacunarity. And there are measures of lacunarity that can complement fractal dimension. So here you see the presence of it depends on whether black is object or white is object. The other is background. So one is the object, the other is the background, black or white. Then the other, if black is the object, then white is a hole. So all these white parts are holes, lacunae. So self-similarity dimension is defined in the number of using the number of self-similar pieces in this pattern. 1 over S is the reduction factor, S is the scale factor, D is the self-similarity dimension. The formula is A is equal to 1 over S to the power of D, and take log. D is log A over log 1 over S, or minus log S. So that's the definition of self-similarity. So the Koch snowflake, if you continue, I showed up to here earlier. If you continue, you get this. One of my students, Tan Nguyen, she did this. I don't know how she did this. I lost patience after doing 3. She went and did this either by hand or I don't know what she used. The fractal dimension is 1.262, and that can be computed using these number of self-similar pieces, these triangles, and the scale. Now that is for self-similar patterns that can be constructed using a rule, and you know what it is, and the formula works. But given a pattern, how do you estimate the fractal dimension? There are a few algorithms in the literature that you could use. So this is the contour given. Contour pixels are patterns. What is inside and outside doesn't matter. The box counting method in 2D says, you can do in 1D also, superimpose a grid of some scale, this box, and count all the boxes that have some piece of the pattern, all the highlighted ones. Change the scale, make the box smaller, using some like half, 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 and so on. And again, do the same thing, and keep doing that. Count the number of boxes with some part of the pattern in it. And then plot that. Log of number of this versus log of scale, 1 over scale, 1 over S. And if it is a fractal, there should be a straight line of this. It's approximately straight line. It's 1.26. The theoretical one is 1.262. We got 1.264, which is good. So for the Koch snowflake, not for this mass. Right? Yeah, I'm showing a mass here, but this is for the snowflake, 1.26. There is another type of pattern. There is a category of patterns called space-filling curves. The Peano-Hilbert curve is defined in this manner. There is this grid at some scale, and you should visit one point in each of these subdivisions. And there is a certain rule of visiting them, and that is, you should visit all the elements in your image without backtracking. You should not visit the same place twice. And the curve should be, it's not continuous, it's not differentiable, but there is a certain pattern so that you visit all of the points in the image, but you must visit all points in a certain vicinity or neighborhood before going farther out to other sub-blocks. Then you're moving farther away. So the idea is you visit the nearest points in some sense, in a certain pattern, and then visit all the other parts of the grid or image. These could be pixels in an image. You're scanning. Instead of raster scanning row by row, visiting elements row by row, because you're going like that, you're going far away from the starting point, and then you come back and say, oh, but then you're close to the starting point, the first element. Then you go like that and come back here. You're again close to the starting point, but you went that far. So this method says, don't keep going like that. Instead, visit all the elements within this block, and then go to the next block. Visit all these, and then go to the next, and then go to the next. There's a rule for this. I won't go into those details. One of my students, Joseph Provin, did his master's on using this pattern to scan digitized images and compute prediction models. We thought we would get better prediction because you're visiting neighboring pixels before going farther away. If you go like that and come back, then the correlation between this point and that point is not much. And then you come back again, there is high correlation. So at different scales, you see this pattern, but if you take this pattern, this is the same, turned around. And you come here, this pattern is the same as that. And this is the same, and that is this flipped. And that is this thing turned. So it is this pattern that appears repeatedly at different orientations and scales. And then you get these other more complex patterns. But this is called a space-filling curve. the entire 2D space is filled by this curve in the sense it visits all the points, the center points of all these little squares. That is a pixel, let's say. It could be some graph, it could be something. If it is a digital image, we can call each of these centers as a pixel. So you visit all these pixels in this quadrant and then go to the next quadrant, but you go from here to here, here and there. That's the basic pattern. But if you take this pattern, the same thing appears here, reflected, reflected. And the same pattern keeps on going. In the next stage, all of this will appear in blocks. So this is that a fractal? You can argue both ways. It's a space filling curve, that's what it's called. It's a fractal in the sense there is nested complexity and there is self-similarity, the same pattern. And nested, the same thing is appearing here with rotation. So we could call that a fractal too. So breast masses and tumors we have seen. Benign masses are round, oval, smooth, macrolobulated, homogeneous, well-defined, well-circumscribed, sharp edges. Malignant tumors due to breast cancer are spiculated, rough, microlobulated, heterogeneous in density. That doesn't matter in terms of contours and shapes, but it matters in frequency content. Ill-defined, ill-circumscribed, and blurry. So those are from BIRADS and from our discussions with the radiologist. Here are some examples. Going from benign round to benign macrolobulated, malignant microlobulated, malignant spiculated. Contours drawn by Dr. Desertels in the grayscale images. Okay. The ruler method to estimate the fractal dimension says, let U be the length of a contour, but the length varies depending upon your measuring scale. The larger the scale, the poorer the accuracy of measurement. In the sense that this concept is, there is some contour and you want to measure its length, and if my ruler is of this size, if I start from here, the next point will be where it intersects. So this is my ruler size, ruler rather. This is the starting point. Then I say, take this and intersect, like calipers, your divider. You say, okay, next point is that. So I'm measuring that. All of this is lost. And from here I say, where do I intersect next? That. And so on. If I use a smaller one, I don't know, this one. So then I'll measure this, and from there this and this. So I get that length. I get a more accurate length of the contour. So that is the effect of the scale, or the scale of your measurement, in the sense this dimension of the length of this ruler. So if it is, they always say the contour of a British island, I don't know why it has to be British, it could be Manipal Beach or Malpe Beach. Where is the line? How do you measure it? And it's very jagged. And if you measure like that, depending on your step size, you get different results. So how do you model that? U is C times 1 over S to the power of D, where U is the length of the contour, the whole contour that you measure, and C is a scale factor, and S is the scale rather. C is like how many millimeters that is, your ruler. D is a dimension. The fractal dimension is 1 plus D. You're adding this measure to the Euclidean dimension. If you take log, you get this equation, and if you take the slope of that, you will get the fractal dimension. So in the case of a 2D contour, you can do in 1D, you can do in 2D. So this is a malignant tumor boundary drawn by the radiologist, and if I use this ruler size, that is how I measure. If I use a smaller ruler size, you get a different measure, more accurate measure of all the spicules Here these spicules, this is completely lost. The spicules don't get measured accurately. Then plot that and get the slope of the plot, and that gives you fractal dimension with some correction factor depending upon the Euclidean dimension of where you started. The 1D signature of a contour, we have seen this before. We could convert a 2D contour to a 1D signal, if you want to call it so, a 1D function. Not a function of time, but space or something. By computing for every point on the contour some function. It could be some function, it could be the Euclidean distance to the centroid, it could be whatever you want it to be. And you are reducing from 2D to 1D, that's the idea. A signature is a measurement of some property of the contour at every pixel or point on the contour. So a 2D contour may be converted to a 1D signature using the Euclidean distance to the centroid. This is just the distance to the centroid. So a smooth contour gives you a nearly sinusoidal curve. If it is a circle, you will get a straight line. If it is spiculated, you get a more jagged curve. So obviously, like using that example of measuring the coastline, it's easier to measure this with a larger ruler, but for this you need more scales. You can do this in 1D also, like I showed. Large ruler, small ruler. So if you want, you may convert from 2D to 1D. If not, do it directly in 2D, it doesn't matter. These are various possibilities. So for that one of those contours, FD is 1.15. I mean, is that a fractal is a question. Perhaps some of these are not fractals. So the dimension is low. If it is a straight line, it is 1. It is not a straight line. Is it a fractal? Not really. I can't see much of self-similarity and scaling. There is similarity, yes, there are some waves. Is there scaling? No. So the dimension is low, 1.1. Whereas for the other one, you get more. I'll show some numbers later. So one of the data sets, this work was done by Tan Nguyen for her master's thesis. And in her work, she had various data sets. One from the MAIAS database, 54 contours, which were further divided into circumscribed benign, spiculated benign, and circumscribed and spiculated malignant. Dr. Desatel said that categorization is not diagnostically or clinically relevant, just say benign malignant. So from the Foothills Hospital in Calgary, we got this set of contours, well, images, and Dr. Desatel drew those contours. And this also, he drew them. MAIAS database doesn't give the contours, it just gives a circle or a square or something. 37 benign, 20 malignant. So the benigns in the first data set, fractal dimension 1.14 plus minus 0.06 standard deviation, malignant 1.4. Second data set, a better separation. Oh, sorry, this second is MAIAS. MAIAS has this mix-up. There are spiculated benigns I showed you earlier, some benign ones, and some malignants are circumscribed. So there is a bit of confusion here in shape. So for the MAIAS database, we got a classification accuracy of 83%. For the Foothills, this Dr. Desatel was involved in this, so he knows for sure that these are benign and malignant. But that is based on biopsy, not radiologist analysis. So we got 94% with just fractal dimension, one number. Using the ruler method and 1D signatures of the contours. We got comparable results using the other methods. 2D ruler, 2D box, 1D ruler, 1D box, and all that we did. So similar results, some of them not so good. 2D box counting did not work well on the second data set. The MAIAS data set gave a little lower accuracy than our Foothills data set. If you combine both, we got up to 0.89, 0.9. Not bad. Again, using one feature. It doesn't happen like that. Typically, you have a few tens of features. So let's look at the frequency domain interpretation of this, of fractals and fractal dimension. The frequency domain interpretation is based on the fractional Brownian motion that you must have seen in physics, that a particle could be moving at random, some random walk, and the difference between the position of the particle at time t1 and t2 is proportional to t2 minus t1 to the power of 2h. And h is called the Hurst exponent, and that is related to fractal dimension and the Euclidean dimension in this manner. So the variance of this difference in the value of the function at t1 and t2 is proportional to the difference in the time or displacement to the power of 2h. Depending on what you are measuring, these t1, t2 could be time, space, v could be some function, some value measured. Faraz Olomi, he did his MSc and PhD with me on the knee joint sound signal, vibration signal project. We did a fairly big project on the analysis of knee joint vibration. When one swings the knee joint, if there is some arthritic degeneration as you swing the leg, there could be some creaking sound. And that sound has some diagnostic value. There have been some papers in the 1980s on that. We started our work soon after I joined Calgary in 1984. We explored the application of a number of signal processing techniques to categorize these signals. Dr. Frank and Dr. Bell were orthopedic surgeons. They perform arthroscopy. In arthroscopy, a small incision is made and a fiber optic scope is introduced, and the cartilage surfaces and ligaments and so on are analyzed by looking at the video signal you get. They could also insert in arthroscopy in the small, I think there are two cuts made, one to irrigate the joint and the other to put the scope and view. And the orthopedic surgeon can also insert some minor surgical tools and do some minor repair of torn ligaments or menisci and so on. What the orthopedic surgeons had observed is that patients would come complaining of something and they say, my joint is making sound and it's painful and so on. And imaging techniques don't show such detail. MRI can show, X-ray imaging won't show because of the presence of big bones. You cannot see cartilage, which is only 1 or 2 millimeters in thickness. Cartilage is the tissue covering the bone surfaces. Ligaments are hard to see, but maybe in MR imaging you can see. But as I said, MR is expensive, you have to wait. If you just say, my knee is making some sound, you'll wait for months and years. So they felt that, they saw in their clinical practice that a number of patients who were selected for arthroscopy went through arthroscopy and they found there was nothing wrong. So it was a waste. It's a surgical procedure, semi-invasive, but still the patient is under anesthesia, and there is some risk. Whenever you make a cut, there is some risk of infection and other problems. So the aim of this project was to see if the knee joint sounds could be analyzed to understand the nature of the issue. Some sounds could be normal, some related to some abnormalities. Which of the patients would possibly benefit from arthroscopy, and reduce the number of patients coming and going through arthroscopy, the selection procedure, and then being found to have no problem. That was the original problem. We went through many algorithms, prediction modeling algorithms, adaptive filters, adaptive modeling. One of the techniques we tried was fractal dimension. Is that signal a fractal? So we did 1D signal analysis. Using the fractional Brownian motion analysis, these are simulated signals. With the Hurst exponent h being 0.2, the model FD is using that formula 1.8, 1.5, 1.2. Smoother curve, little rougher, more rough, 1.8. So we thought that perhaps knee joint signals related to normal and abnormal knees would have some varying fractal dimension. We found the reverse of what we thought would be the case. Normal joints also have some noise, but that is random, so higher fractal dimension. When there is an abnormality, there is some structure to the sound, and then the fractal dimension goes down. So we had to come up with a different interpretation of that. So how do you do this? How do you estimate the fractal dimension? Based on spectral analysis, you obtain the past spectral density. This is 1D. So there's only one frequency. And that should be proportional to 1 over f to the power of beta, what is called the inverse law or power law. Actually, it's called the power law, with the factor beta being the power of 1 over f. It is also inverse. It is inversely proportional to a power of frequency. So if you forget the factor f, it is an inverse proportionality. The past spectral density should decrease with frequency, which happens in most cases, unless it is random, when it is flat. White noise. When there is structure, the past spectrum decreases with frequency. If there is a linear portion, then you fit a line to that and get the slope of that, 1 over f to the power of beta. And d is 5 minus beta over 2. The factor 5, it depends on the dimension, Euclidean dimension of the signal, 1D or 2D. So these are what we call VAG, vibroarthrographic signals. More of that in my 1D signal processing, signal analysis book that you saw the first day. So these are normal and abnormal signals. They're all very random. Well, they look like they're random signals, but there is some structure. They're not like the ECG where you can see clear patterns. So these are some examples of the VAG signals and their past spectra on log scale. Log of frequency, log of magnitude, and we expect a linear portion. Decreasing with frequency, but do you want that band or this band? This band is fairly high frequency, from 100 hertz up to 1000 hertz. Perhaps after 200-300 hertz, it's all noise. So we took this band to be the significant band, from about 20 hertz to about, what's the band? It's somewhere there, 20 to 300 or something like that. So the line fit is shown there. Now the spectrum is not a smooth function. It has these variations, especially on a log scale. So you still fit a straight line. The abnormal has that slope. Normal 1.8, abnormal 1.3 fractal dimension. We got area under the ROC curve up to 0.75 with a data set of 8 and 9 VAG signals. Just again, one feature. So 0.75 area under the ROC curve is good for one feature. You add more features, you can get better. I'll show the 2D application of that later on. In the case of 2D images, there is a method known as the blanket method. I think I described this under chapter 7. So if you have a flat surface or an image with the same values, you want to cover it with a sheet of cloth or a blanket, you need a certain area of that blanket to cover it. But if this has other things, it is not a uniform surface, you are required to cover everything, you need more of that blanket to cover all of these exposed areas. Everything, every surface has to be covered. So if you have something like this, you go here and come and cover everything. So you require more of the blanket area. So these are pixel values. So the top of the pixel, there is a certain area, depending upon your sampling resolution or pixel size. You have to cover that, cover this, but also these exposed areas in between. If you imagine these to be blocks, like a building towers in the city center. So take these parameters and compute the area as the area of each of those exposed top surface, and then all the differences between the pixel values multiplied with epsilon, and epsilon is your scale factor, and 2 minus the derivative of that and the log scale factor will give you the fractal dimension. Extend that, or rather go back and extend the spectral method that I described earlier with 1D WAG signals to images. You convert the Fourier spectrum, as I've shown earlier, from Cartesian to polar coordinates. And then from polar, you take the marginals versus angle and radial frequency. I showed how to fit a straight line to the radial frequency past spectral density, which is a 1D function for a 2D image. The angle distribution is different, and we quantified using other parameters for architectural distortion. Here, the fractal dimension of the image is related to the slope of the 1D radial frequency past spectral density. So compute the 2D Fourier transform FUV, compute the 2D past spectral density SUV magnitude square, transform SUV to polar coordinates SF theta or SR theta, whatever you want to call it. Integrate over theta to get SF, similarly get S theta by integrating on F. Fit a straight line to a selected range of frequencies of the 1D PSD on a log-log scale, 1D PSD on radial frequency. Determine the slope of the best fitting straight line, and 8 minus beta now, 8 because the Euclidean dimension of the image is 2. So using that, one of the equations I showed earlier, then we get 8 here. So here's a region of interest with architectural distortion, Cartesian coordinate, Fourier past spectrum, polar coordinates, angle, radial frequency. Now this is a fairly smooth one because you're integrating. In the 1D case, you just take that frequency spectrum. That's why it was so noisy. Here, to get this radial frequency, you're integrating on theta. So many values are added. So this is a nice smooth spectrum, easy to fit a line. But we need to specify a range. You don't want to fit a line to the whole thing. There could be some very low frequency information that we are not interested in. There could be some very high frequency part of the spectrum where you have noise. So find a middle range, log-log scale, fit a line, get the slope, get the fractal dimension. Beta is the slope. So these are synthetic images. One of our colleagues in the Faculty of Medicine had developed a program to synthesize fractal images using the fractional Brownian motion model. And these are 3 synthetic images. This looks like a mammogram. This also could be a mammogram, maybe even that, part of a mammogram. Model fractal dimension based on the parameter used to synthesize 2.2, 2.4, 2.6, rougher as the fractal dimension increases, rougher texture. Blanket method gave 2.5, 2.57, 2.7, increasing, but the increase is not that much. The past spectral density method did not give much of a difference, 2.66, 2.67, 2.68. That's not a significant difference. If you take the p-values over a number of such images, perhaps this will be insignificant. This could turn out to be significant from this to this and this to that, or rather from here to there and here to there, maybe not here. But that's not what we wanted to do. One could do such analysis to see if these differences are statistically significant. So we put together a number of shape factors. Tan, for her master's thesis, did this work. compactness, convex deficiency. I have defined all of these earlier. Points of inflection, get the polygonal model, and get the fractional concavity. We saw all of this, right? If you remember. And speculation index we saw. So no need to go through them. Fourier descriptors we have seen, and normalized Fourier descriptors to compute this FF we have seen. So now we have our data set of contours and some examples of this feature vector of fractal dimension using, it is somewhere else. I can't remember which method was used. And compactness, speculation index, the Fourier factor, fractional concavity. Fractional concavity works well. We expect this to increase, A, B, C, D. And all of them are increasing as expected. Okay. The grayscale image, the contour drawn by the radiologist, and a feature vector now. So that's a feature vector. So the data set was rank ordered using fractal dimension. In the publication we have the details using different methods to estimate the fractal dimension. I have lost that here. So benign, B is benign, M is malignant. Most of the benigns are up there, some malignant. These are misclassified if I put this threshold. As I vary the threshold, I get the ROC curve. Benigns mostly up to 1.3 or so, and then mostly malignant up to 1.7. Another data set. This is the MIAS data set. This is our data set from the Foothills Hospital in Calgary. This is from the MIAS data set. That is the very first one, speculated benign, but it still is only 1.04. So these are going there, and let's say the threshold is 1.28. We have several misclassification examples here, going to 1.5. So in Tan's work, she did various pattern classification experiments using the Fourier factor, area under the ROC curve, 0.77. Compactness gave very good result, fractal dimension comparable, and through feature selection, various combinations were selected. The fractal dimension with fractional concavity gave the best result of 0.93. For the combined data set of 111 contours, a ruler method on 1D signatures for fractal dimension. So there are significant differences in the fractal dimension of contours of malignant tumors and benign masses. The grayscale variation did not give us very good result, but that could be due to the nature of the images we have. Maybe with digital imaging you get better grayscale sensitivity and better representation without much noise, then you may be able to find fractal dimension computed using the frequency domain method also useful. It depends on the type of images you have. In any case, shape analysis using fractal dimension gave us very good results. And when combined with other shape factors, we got even better results. So fractal dimension can serve as a useful feature, one of the features in a set of features, and could also assist in the analysis of biomedical signals such as lag and EMG. There are several papers showing the usefulness of fractal dimension in the analysis of EMG, electromyogram, muscle electrical signals related to contraction and fatigue, development of fatigue. If you hold the contraction too long or do some exercise repeatedly, then the muscles develop fatigue and the signal characteristics change. So how do you characterize that? And how do you characterize different levels of contraction of the same muscle using the EMG? Fractal dimension has been useful. We did, let me say, Dr. Desertel again, Tan did her master's on this topic, Liang did his MSc PhD, Naga did his PhD, Neema came from Egypt and she did part of a PhD, and Hilary did a PhD with me. Shantanu did his PhD, Faraz did his PhD. Lucas came from Brazil and did his work on that vertebral compression fracture. So all of them used some parts of this and gave me some illustrations. Now we did a number of other experiments using full field digital mammograms also from my collaborators in Italy. They gave us a data set of contours of masses drawn by radiologists on digital mammograms, full field digital mammograms, the FFDM. So we had 3 data sets, 2 that we had and which is which, it's in the paper. I can't remember which is which here. There are 3 data sets. So these shape factors gave good results. 9, these are area under the ROC curve, individual shape factors. But in one of the data sets, the results were not so good. This must be the Maya's data set. This must be the Calgary one. This must be the full field digital. I can't remember. And then we did various cross validation across the databases. You train with this and test with that and put them together or not, and then use different classifiers, linear discriminant, quadratic discriminant, radial basis. I think Dr. Narasimhadhan will talk about some of these classifiers later. And different data sets, train with this and test with that, all of that. So lots of these results, but sometimes going up to 0.99 with just 2 factors, 2 features. Sometimes more features were selected, but the results are poorer. So it depends on the classifier or selection process, which features are selected. So you get different results. 12:30, well, that's good. Any questions about fractals and fractal analysis of signals or images? I'll put up PDF files of all of these new. This is not new, but one will be new, the others are there, but I haven't transferred them yet. At the end, maybe in a couple of days, please look into that Google Drive and download all of the files. Any questions before lunch?
You saw one of the example of the knee signaling. So I want to know that how did you classify the other ends to be noise?
Other?
The data parts to be as noise.
No. From analysis of the signals and knowing the bandwidth of data acquisition, the filters used before sampling, we estimate a certain range to be bearing useful information and certain very low frequency information to be not of relevance in classification, and very high frequencies within that band to be noise. It's just estimated by analyzing the signals and their spectra by visual analysis. The classification of the pathology was done by the orthopedic surgeon. All of them underwent arthroscopy. So the classification of normal or abnormal, we didn't go into subcategories as to whether it is cartilage or ligament or arthritis or something else. We just did screening, normal, abnormal. When I showed that spectrum, what I wanted to emphasize was you have to select a range over which you will fit the linear model. There will be noise, especially in the 1D case. In the 2D case, it was a smooth spectrum, but even then, there is some variation in the low frequency range, and that's not a straight line there. And after that, it goes down, and there is no straight line there, but there is some band where there is this straight line proportionality, where there is a clear straight line over which we can compute a slope to fit the spectrum. If you fit it for the entire range, it will not work well. So we need to define some bandwidth over which we will fit the spectrum with a straight line, and then compute the fractal dimension from there. That is by inspection of the signals. There's no rule for that as such. But from data acquisition, we know the bandwidth over which we have acquired the signal. And by analyzing the signals in our data set, we are able to make some judgment as to where the useful frequency components stop. Then we say the rest is noise. Noise in the sense not desirable for this process of fitting a straight line.
So there were two signals actually. We compared the normal one and abnormal one.
Which one?
There were two images comparing with normal one and abnormal one. So for that normal knee also we had to take the signals this way to quantize the other abnormal one.
For the normals also, what?
We had two pictures there,
Yeah.
the signal of the normal knee and
Yeah.
the abnormal knee. So to quantify this abnormal one, did we take signals of the normal knee as well?
Yes, we took signals from all the patients who were scheduled to go on arthroscopy during the period of our study. We also took signals from patients who had gone there for examination, and they were found to be, by clinical observation, to be normal. Not all of them went through arthroscopy. That categorization was done by the orthopedic surgeon. And we had volunteers also from our department and neighboring departments to go, but they would be evaluated using some questionnaire to determine if they are normal or not, meet the criteria for clinical definition of normality, and then the signals were acquired in the lab. Yes, so we did acquire normal signals also in the lab. Is that what you asked?
Yeah.
Yeah, yeah.
Thanks.
So it's kind of a detour from what we are talking about, but this is as regards getting this MOA, okay, with the clinicians. Because I faced a similar problem, okay, when I started working on my stuff in CXR, okay, chest X-ray. So I approached a couple of hospitals over here, and I just wanted them, kind of to get affiliated with them so that they can provide me the clinical insights. Because the VINDR CXR I got it has only bounding blocks, there's no specific ground truth, okay, as regards to what I'm looking at. So most of what they said is, they normally bring the problem statement to us, and not us going, we design something and then we want them to, give their insights. So I wanted to see, know how is it like over there, because I remember I visited ISC, Prof. Pandya is there, like a young researcher. So there I met most of these radiologists. They actually came with the problem statement and they were there in the university, talking to them and showing them things. So I want to know, how is the research scenario over there? Like, is it like, they will tell you exactly, or you just have to?
Yeah, I think there has to be a lot of give. There has to be a lot of give and take and discussion. It doesn't happen in one day. What I have said in my book and what I tell when we discuss points like that is, we need to go around and talk, knock on doors. And just like politicians come to you and knock on your door and ask for your vote, I'm not asking for anything when I go there, but I have to go there. I'm interested, they're also interested, but they need to know what I can offer, and I need to know what it is that they want. So soon after I joined the University of Calgary, I had prepared some seminars on what I had done before that, and then I went and met them. I called around and asked them, I want to do some signal processing, biomedical signal processing. Is there anybody interested? So we went to cardiology and had a couple of students, collected some heart sound signals and so on. And they said, well, heart sound signals, we're not interested. I was a bit surprised. I said, well, they said, we have ultrasonography now, we don't use heart sound signals. What is this thing hanging around your neck? Everybody has a stethoscope. Nurses have stethoscopes and doctors have. So this is hanging around your neck, and that's your symbol of your profession. And the first thing they do is check your heart sound. How can you say heart sound is not relevant in diagnosis? But anyway, they didn't want that. Then I said, what? And then we discussed various projects in cardiology. Nothing clicked. And then somehow I got introduced to Dr. Cy Frank in orthopedics, and he said, well, we had a joint injury and diseases research group, later on renamed as Joint Injury and Arthritis Research Group. a very multidisciplinary research group with orthopedic surgeons, clinical specialists, and various medical specialists, mechanical engineers, civil engineers, and electrical. So they said, okay, we have a research group, we have weekly seminars or whatever, monthly seminars, come and talk. I went and talked about some signal processing, ECG, or whatever I had. Well, they said, oh, that looks interesting. We have these signals, we have knee joint signals. So they didn't want ECG and heart sounds, they wanted knee sounds. I said, any signal is a signal. Tell me the difference between A and B and we can do something. And that's how the knee project developed, and we worked for many years. We had to collect signals. It took months and months. And one of the reasons we have long list of authors is we had 2 orthopedic surgeons. We had a medical science student. She was handling the patients and recording the signals. I had a postdoc fellow who was doing the signal acquisition and bringing the signal to the computer lab. And I had a grad student. So the list grows. So it is not just me sitting and writing this paper. Impossible. So 2 orthopedic surgeons, a medical science student, a postdoc fellow, and a graduate student, and myself, 6 authors. So when this goes to the Dean of Engineering, the Dean says, wow, why do you have 6 authors? What is your contribution? I can say, without me, this wouldn't have happened. That is selfish. And so, but then it is a team effort, right? So there are some, we call them bean counters in administration, even in university administration, and in granting agencies. They say, oh, you are the 3rd author. And there are 6 other authors. What is your contribution? Divide by 6? Okay, whatever. So this is how the projects develop. That discussion takes months. To develop this knee joint project, it took us months. And we wrote a few conference papers along the way that, well, this is what we have explored and studied, and this is what we have recorded. And it grows, the database grows, the complexity of methods. We try the known methods first, linear prediction modeling, spectrum analysis, then adaptive modeling, adaptive filters, fractal analysis, and various statistical measures. How do you break the signal into stationary parts? So it goes on then. Once that relationship is developed, then we can bring in all the advanced signal processing methods that we would like to try. And the interpretation is still in consultation with the orthopedic surgeons in this project. Similarly, I went to radiology and said, well, I'm interested in medical image processing. And the head of the department said, go and talk to Dr. Desatel. Before him, there was a Dr. Morrish. So they said, okay, come and tell me what. And I said, X-ray images. And well, chest X-ray images, I don't need anything. Mammograms, we need help. Because mammography screening was new at that time. So then, yeah, it switches. But I had worked on mammograms before. I knew about the screening program. And they tell me more. And then slowly it starts. We will enhance contrast, we will detect calcifications, and you saw that whole story. So that takes 30 years of work. So these things won't happen in a matter of a day or 2. But that's why tenure is important. I'm a tenured professor, then things can go slowly. The other question that I'm asked often, sorry, I'm taking a little longer. Other question I'm asked often is, did you develop a product? Has your method been useful? How many patients did you save? No, I cannot claim that I have saved even one single person. That's not the idea. We are professors and we are researchers, and we add to the knowledge base. And there are some who recognize that. Not many people recognize what is this knowledge base. All the papers that you write, all of you write papers and publish in conference proceedings and journals, that is the knowledge base. And you write about this, and the next person writes something more, better about that, and better, and the knowledge base grows. So based on all of that, the next generation will be smarter and better. So in Telugu, there is this Guru Minchina Shishyidu. They say, so how can the student be better than the teacher? But that is possible. It has to be so. Otherwise, there will be decay, right? So the next generation has to be smarter and better. So there is nothing wrong. You can't claim that. I won't go and tell my professor that I'm better than you. But based on what I learned from him, I have other experience. And based on all of this, you should have something more and develop something better. And when you give that to your student, that student should do even better. And that's how the knowledge base grows. And to take this to clinical practice is a totally different thing. I'm not a business person to develop a product and sell it. Even patenting, many of our professors, and I also took the opinion that we will publish, put it in the public literature. This was funded by government sources of public money, or cancer societies that have raised fund by public donations. You give $5, $10, and they give us some grants. So that is public money. So I can't hold that and say I'll get a patent and I'll make money. The university wants a cut of that too, of course. But the university can help in getting the patent. Getting a patent takes 3, 4, 5 years. Turning that into a product, that is totally different. There's no research involved there. And I want to do research. And the thing is published. You are interested in develop a product, go and do it. Not mine. There are hundreds of such methods. You select the best. Compare them and develop your product based on what you find to be the best available method. Will you make money? I don't know. But to take that to the level of a commercial CAD system, it takes years and millions of dollars of investment. And that's not my interest. Right? There are some who may be interested in doing that. Fine, go ahead and do it. But that's a different path. That cannot be done without this knowledge base. Somebody has to create this knowledge base. Anything else?